Topic: Diarrhea. Contents. Objectives. Introduction. Definition of diarrhea. Etiology. Classification of diarrhea. Types of diarrhea. Pathophysiology. Classification of dehydration. Clinical features. Investigation. Medical treatment. Nursing care in diarrhea. Complications. Nursing care plan of diarrhea. Summary. References. Objectives. At the end of this presentation, we will be able to define diarrhea, etiology, and pathophysiology of diarrhea. Define the classification of diarrhea. Explain the diagnosis and treatment of diarrhea. Introduction of diarrhea. Diarrhea means that you have loose, watery stools more than 3 times in one day. It may have also other symptoms such as cramping or nausea. Diarrhea can be a serious and life-threatening condition. However, some forms of diarrhea can be prevented. There are certain things people can do to lessen the symptoms of diarrhea. This focuses on causes, prevention, and treatment of diarrhea. Diarrhea. Passage of 3 or more stools in a day, of consistency softer than usual for child, or 1 watery stool is defined as diarrhea. Or, diarrhea is an excessive loss of water and electrolytes with passage of 1 or more unformed stools. Etiology. Infections of the gastrointestinal tract are caused by a wide variety of enteropathogens, including bacteria, viruses and parasites. Bacteria. Escherichia coli, 25%. Invasive. Enterotoxic. Enteropathogeny. Hemorrhage. Salmonella, 10%. Shigella, 5%. Vibrio cholera, 5.10%. Staphylococcus aureus, food poisoning. Campylobacter jejuni. Yersinia enterocolytica. Viruses. Rotavirus, 40%. Enterocadenovirus. Parasites. Entamoeba histolytic. Giardia lamblia. Cryptosporidium. Fungi. Candida albicans. Causes of diarrhea. Classification of diarrhea. Diarrhea classified into 3 categories. 1. Acute diarrhea. 2. Persistent diarrhea. 3. Chronic diarrhea. 1. Acute diarrhea. Acute diarrhea is short-lasting between several hours and number of days and for less than 2 weeks or 14 days. Acute diarrhea include cholera. If acute diarrhea is blood, then it is called dysentery. 2. Persistent diarrhea. Persistent diarrhea lasts for longer than 2 weeks but less than 4 weeks. 3. Chronic diarrhea. Chronic diarrhea lasts more than 4 weeks. Types of diarrhea. 1. Osmotic diarrhea. 2. Secretory diarrhea. 3. Inflammatory diarrhea. 4. Motility disorder. 1. Osmotic diarrhea. Occurs when small intestine cannot absorb a soluble compound and fluid drawn into the gut. 2. Secretory diarrhea. Results from active chloride secretion into the bowel. Water follows the chloride ions, leading to net loss of fluid. 3. Inflammatory diarrhea. Inflammation of the intestinal lining. 4. Motility disorder. Motility of the intestines is increase. Pathophysiology. The pathogenic organisms produce diarrhea in the susceptible host. Pathogenic organisms adhere to the intestinal mucosa wall by diffuse adherence. Then liberate the exotoxin and that cause diarrhea. Dehydration results from loss of water and electrolytes. Following are effects of diarrhea. 1. Loss of water. Loss of skin turgor. Weak or absent pulse. Sunken eyes. Sunken fontanelle. Husky voice. Cyanosis of finger. Dry mucous membrane. cold skin. Anuria, uremia. 2. Loss of nutrients. Hypoglycemia, convulsions, coma. Loss of weight, marasmus. 3. Loss of bicarbonate. Vomiting and retching. Deep and sighing respiration. Irritability, increase O2 demand of brain. Myocardial contractility is decreased. 4. Potassium loss. Abdominal distension, paralytic ileus. Sustained shock. Classification of dehydration. 1. Clinical. Mild colon when weight loss is less than 5%. Moderate colon when weight loss is between 5 to 10%. Severe colon when weight loss is more than 10%. 2. Biochemical. Isotonic colon, 70% of cases, when serum sodium level is between 130 to 150 meters mol/L. Hypotonic colon, 20% of cases, when serum sodium level is less than 130 mmol/L. Hypertonic colon, 10% of cases, when serum sodium level is more than 150 mmol/L. Clinical features. Sudden onset of diarrhea. Nausea. Vomiting. Stomach pains. Stools are large in volume. Stools are watery green in color. Sudden loss of weight. Dehydration. Mild dehydration colon. Infant is colon. Irritable. Restless. Thirst. Feeds are taken eagerly. Vomiting. Anterior fontanelle is slightly depressed. Moderate dehydration colon. More irritable. Eyes and fontanelle sunken. Skin wrinkled. Extremities feel cool and cyanosed. Metabolic acidosis. Deep, rapid and sighing respiration. Thirst. Severe dehydration colon. Condition become critical. Oligemia, total blood volume reduced. Peripheral circulatory failure. Skin is cold. Extremities deep cyanosed. Desire to suck loss. Cornea are glazed. Eyeballs rolled upward. Fontanelle deeply sunken. Urine output cease. Investigation. Blood count. Stool examination. Serum electrolytes, Na+, K+, and bicarbonate, HCO3. Urine examination and culture. Blood culture, salmonellosis or shigellosis. X-ray chest. Medical treatment. Plan A, for no dehydration, treat diarrhea at home, counsel the mother on 3 rules of home treatment. 1. Give extra fluid. 2. Continue feeding. 3. When to return for follow-up visit. 4. When to return immediately. 1. Give extra fluid. A. Teach the mother how to mix and give ORS. B. Tell the mother to colon. Give frequent small sips from a cup. Continue give extra fluid until the diarrhea stops. 2. Continue feeding. Continue to breastfeed frequently. If the child is not breastfeed, give cow's milk or formula milk, half diluted for 2 days. If the child is 6 months, after rehydration, give freshly prepared food like cereal with pulses. Vegetable. Give fresh fruit juices or mashed banana. 3. When to return for follow-up visit colon. Advise mother to come after 5 days for follow-up. 4. When to return immediately colon. Advise the mother to return immediately if the child has any of these signs colon. Not able to drink or breastfeed. Becomes sicker. Develops fever. Blood in stool. Drinking poorly. 5. Treatment B, for some dehydration. Treat some dehydration with ORS. Give frequent small sips from a cup. If the child vomits, wait 10 minutes, then continue, but more slowly. After 4 hours, reassess the child and classify child for dehydration. Select the appropriate plan to continue treatment. Give feeding the child in clinic. Medical treatment. Treatment Plan C, treat severe dehydration quickly. Give IV fluid immediately. Give 100 ml, kg Ringer's lactate solution. Age first give 30 ml/kg and then give 70 ml/kg in. Infants, under 12 months, 1 hour 5 hours. Children, 12 months up to 5 years, 30 minutes 5/2 hours. Repeat once if radial pulse is still very weak. If hydration status is not improving, give the 1/V drip more rapidly. Also give ORS, about 5 ml/kg/hour, as soon as the child can drink. Reassess the infant after 3 hours and a child after 6 hours. If you cannot give 1/V fluids, then use a nasogastric tube for rehydration. Start rehydration with ORS through NG tube. Reassess the child every 1-2 hours. If there is repeated vomiting or increasing abdominal distension, give the fluid more slowly. Fluid for concurrent losses: 5% dextrose half saline is given 50 to 70 ml/kg in next 6-8 hours. Potassium replacement is usually started when urinary flow has been established. Potassium should be given in drip. Bicarbonate is given in severe metabolic acidosis. Antibiotics should be given according to antidiarrheal agents. Dietary management should be done during diarrhea. In infants, breastfed should be allowed. In children, adequate calories should be given. Symptomatic treatment should be give. Nursing care in diarrhea. To monitor intravenous fluid therapy, which has been appropriately calculated by the pediatrician. 1. Fluid ordered as maintenance or replacement depending upon degree of patient's dehydration. 2. Fluid is calculated carefully so as not to overload circulatory system. A. Check flow rate and amount absorbed hourly and totally. B. Check intravenous site at regular intervals. 3. Use appropriate devices to prevent patient from vomiting. 4. When preparing solution for therapy, use sterile solution and equipment. 5. Weigh patient daily. 6. When oral feeding start, carefully observe to prevent circulatory overload. 7. While patient is given nothing by mouth, special mouth care should be given. Change position and give good skin care. 8. Vital signs should be recorded. 9. Maxillary temperature only should be recorded. 10. Note any changes in vital signs. 11. Observe for any complications. 12. Note stool characteristics and number. 13. Note activity and conscious level. 14. Note vomiting. 15. Record urinary output. 16. Check presence of edema. 17. To prevent spread of infection by using good hand washing. 18. Care of nappies. 19. If diarrhea is mild, ORS should be given. 20. During diarrhea, brat diet should be used. Banana, rice, applesauce, toast. 21. To provide support for the family, especially the mother. 22. Reassure the mother she is not the cause of her child's illness. 23. After the cause of diarrhea is determined, it may be necessary to teach proper artificial feed and bottle feed. 24. Parents may need help in understanding the symptoms of a sick child. 25. Help parents understand the importance of medical care and general good hygiene. Complication of diarrhea. 1. Dehydration and shock. 2. Metabolic acidosis. 3. Paralyticalus, hypokalemia. 4. Convulsions and coma. 5. Malnutrition. 6. Acute renal shutdown. 7. Persistent diarrhea. 8. Superratid infections. 9. Thrush. 10. Diaper dermatitis. 11. Scleroderma. 12. Death. Nursing care plan of diarrhea. Assessment. Subjective data. Patient's mother give the history of loose motion, vomiting, cry. Objective data. I assess the patient vital signs. Temp equals 98 F0. Pulse equals 160 per minute. Resp equals 60 per minute. B.P equals 90/50. Restless. Skin wrinkled. Sunken eyes and fontanelle. Dry mucous membrane. Skin cold. Nursing diagnose. Loose motion evidence by clinical features of dehydration. Planning. Short-term goal. Rehydrate the baby. Give antiemetics to control vomiting. Continue breastfeeding. Long-term goal. Prevent from infection for further complications. Implementation. Intervention. Maintain IV line. Proper environment. Maintain electrolytes. Maintain intake-output chart. Give antibiotics. Rational. To prevent from dehydration, hypoglycemia and shock. To prevent from hypothermia. Prevent from fits and to maintain all body functions normal. To prevent from anuria. To prevent from infection and diarrhea. Evaluation. Now patient's condition is better and comfortable. Dehydration is reduced, patient feeling well and no irritation. Vital signs and stable. Patient feeding improved. Patient mother is satisfied and full education about disease and healthy diet. Goal is achieved. Summary. Passage of 3 or more stools in a day is called diarrhea. Diarrhea may be acute, persistent and chronic. During diarrhea, dehydration may be mild, moderate and severe. Diarrhea treated according to the severity. References. Jones and Bartlett, 2007. The Pediatric Emergency Medicine Resource. 4th edition, USA. Peril Data, 2007, Pediatric Nursing, 1st edition, New Delhi. Jones and Bartlett, 2003. Core Curriculum for Pediatric Emergency Nursing. USA. Richard E. Berman, et al., 2002, Nelson Essentials of Pediatrics. 4th edition, USA. Barbara F. Weller, 1990. The Lippincott Manual of Pediatric Nursing, 2nd edition. New York. Margaret G. Marks, 1998. Introductory Pediatric Nursing. 5th edition, New York. James H. Hutchison, 1986. Practical Pediatric Problems, 6th edition, London. D. B. Jelliffe, 1985. Child Health in Tropics, 5th edition. Britain. www.skinsheen.com. Diarrhea Wikipedia, the free encyclopedia. Thanks.